Thank you, Dr. Nitin. Thank you very much for this generous introduction. Good afternoon. I'm really happy to see that people are forfeiting their lunch to be here, which shows a lot of interest. Any new technique, when comes, there are always questions, and I really appreciate what Dr. Bhavikar is asking. Why ablate? Why have a new procedure when we have a fantastic procedure already on hand? And therefore, this is going to be a little update on SMILE. I'm a consultant for Carl's Eyes. I had this opportunity to study this particular procedure in its infancy. In fact, there were only 250 eyes which were done in the world, and we took the baton and did the next 1,000 and made it commercially possible to be released. SMILE is a very unique procedure. It offers a flap-free, blade-free alternative to LASIK, where no excimer laser is needed, and a refractive lenticule is carved out within the cornea using a femtosecond laser, and this is then removed through a small incision, and therefore the name SMILE, not just because it puts a smile on the operator's as well as the patient's face and their eyes. A little video for the uninitiated ones who have not really seen a SMILE procedure. It has a curved contact glass. It's a femtosecond laser by Carl's Eyes. It's called VisuMax, which can do this particular procedure. The contact glass sits on the cornea, so it does not raise the pressure in the eye to the same extent as other femtosecond lasers do. This is the first pass they're getting made, which separates the posterior part of the cornea from of the lenticule from the cornea. This is followed by a side cut and quickly followed by a second incision, which is more anterior, and it forms the lenticule. The last incision is a small incision, which allows you to access these particular planes. So when you open the incision and enter, you have to make sure that you are in the first plane, the anterior plane, and then separate the posterior one. Luckily, the VisuMax is having an attachment of a surgical microscope, which allows you to work at the depth of focus and the working distance that you are used to with your surgical microscope. It also has a slit lamp attachment, so if you are having any difficulties in finding the plane, you can turn it into a slit and view where you are going. The second plane, again, is a little more difficult to separate because it's more adherent, but you can see a simple blunt instrument getting used to separate both the planes. There is a whole plane of tissue which is added to the entire lenticule, which does not allow the edges to become zero, and this can be varied from 15 microns to 25 microns. So one of the concerns that how do you treat small myopia, that the lenticule will become too thin, is not really a great concern. I've treated as low as -0.5 with 0.25 cylinder without any issue. Once you remove the lenticule, the cornea is left, you don't really need to go in and wash, so you are not introducing anything into the interface, and the cornea actually smiles back at you at the end of the procedure. It began in 2006 with Professor Walter Secundo and Marcus Blum in Germany, who commenced their first clinical study, and they published the results for their initial study in a procedure which was called FLEX, in which still a flap was created and the lenticule was peeled off. They showed that the procedure was feasible, was accurate, but that the visual recovery was too slow as compared with LASIK. And this is the study I think that people still remember and still feel that the visual recovery in SMILE is slow. It's no longer the case. Now there are lots of changes. In Center for Sight New Vision Vadodara branch, we started this study in August 2008. And so far, we ourselves have treated about more than 6,000 eyes over 7 years. And all the centers put together, if in Center for Sight, must have treated more than 12,000 eyes now. It was very well seen that even in the initial studies, that it was a very predictable, accurate, and stable form of treatment. And this was without any nomogram adjustment, even in the first 250 eyes. This is the aspect of SMILE which has not changed or changed very little, even though many other aspects of the treatment have changed, like better energy parameters, spot parameters, different scanning patterns, higher frequency and better surgical techniques and instrumentations. And we have found that more than 98% of all eyes are within plus or minus 0.5 diopters of intended correction, which for excimer laser we needed almost 10 years to achieve. And this is born out of several studies, not just our own. The study in Japan showed 100% of the eyes within plus or minus 0.5. Our own study showed 95% of the eyes, of course, with the older laser. And in Denmark, where they treated mainly the high myopic group, a plus or minus 1 diopter. Why does this happen? This happens because you are doing corneal reshaping without ablation. Excimer laser, even though is a fine tool, has its limitations, and all of us have felt that. I know once I had to postpone a whole surgical section because in Bombay, you know how small the spaces are, and the neighbor was painting his house, and we being in that building had fumes coming into the laser OT, and there was so much smell that my laser didn't function that well that day, and I had to postpone a whole surgical section. There are so many things that the excimer laser gets affected by. Organic vapors, depth of ablation, corneal hydration, humidity, and so on and so forth. Also, the photoablation rate increases linearly with fluence beyond a certain threshold. And all of us have experienced that it results in a scatter, especially for the treatment of high myopia. SMILE uses cutting instead of ablation, which is a binary process instead of linear, with much less influence on the external factors. And with all this, with little less energy input into the eye, even as compared to femto-LASIK, resulting in less inflammation and higher stability of refraction, as is seen here by an elegant study which was performed in Singapore, where they showed that at any depth of correction, the inflammation still remained the same in ReLEx SMILE, but in LASIK, as you treated more and more diopters, you had more and more inflammatory reaction. Results, I'm very happy to say, we could actually do in 25 high myopic eyes in the form of study. One eye femto-LASIK, the other eye SMILE. And this is a head-on comparison. And we could do it because we were sure that we would have the patient not coming back unhappy with the SMILE eyes. And we could see that in a femto-LASIK, while there are ups and downs in the best corrected visual acuity, in SMILE, it always shows an increase. And as regards stability, in femto-LASIK, we do have some regression. So also in SMILE, in those high myopic group, but the results are much more stable as compared to femto-LASIK, and this was also statistically significant. As regards efficacy, we had more eyes in the SMILE group reading more number of the ERTDS letters, EDTRS letters as compared to femto-LASIK. And Dr. Bhavikar, it does not induce more aberrations, which we are trying to prevent by doing a wavefront guided treatments. What we are actually doing is not really treating those aberrations that are already present, even with our excimer laser, but trying to reduce the induction of aberrations that we are going to produce because of our procedure. And because we are cutting out a lenticule which can be in a prolate form, the induction of aberrations, as shown by many studies, have been much less as compared to what you would have in a femto-LASIK. In our own study, it was less than 0.12 micron. And therefore, we have to understand this is a totally new entity. It's not LASIK. In LASIK, you have induction of aberrations because you would have shots falling at the periphery of the corneal curvature, which has losses in energy, which needs to be adjusted in some way. Here, you are cutting out a lenticule, and the lenticule depth is absolutely well controlled. And therefore, the contour that you get of the lenticule which comes out is going to have the shape that you desire and not something that you need to act upon. And therefore, the induction of aberration is much less, and therefore, you don't need the transition zones which are essential for an excimer laser procedure. And as you can see here, it also reflects in the point spread function. And you can see the SMILE eyes have scored much better as compared to the femto-LASIK eye. And this is, mind you, the same patient's 2 eyes. Again, if you look at the image simulation, much better in the SMILE eye as compared to the femto-LASIK eye. And this is also because the zone of treatment that you get is a true zone of 6 millimeter if you have attempted 6, as against in femto-LASIK where you would have, as you can see here, not a really truly 6 millimeter zone. Long-term data, and we are in the process of studying it, and we've already have 125 eyes which are at 5 years, and those patients have come back for follow-up. And we have a record for them, and we have found that they have much better efficacy and predictability, and therefore this is truly a paradigm shift in refractive surgery. I will come back to retreatment little later. Other advantages are that there is no flap, and therefore no risk of flap displacement. However thin you slice, you are still going to make 2 parts, and therefore there are chances of it moving. Here, there is no chance of that eye having any movement of the flap, and therefore people, especially who are in, say, scuba diving, in contact sports, in pilots, in astronauts, this would definitely have an edge because you have no danger of that flap displacing at any height, at any depth. The small incision also means less dry eye, and this has also been proven. There is a better patient workflow. There's no need to change stations and to change from one laser to another. And patient just loves this idea of not having a flap in their eye. So in conclusion, it's a technique which has come of age, shows across several studies remarkable accuracy, stability, safety, and it is comparable to, or in high myopic group, I would say superior to femto-LASIK. And in the next decade, it is very likely to become the technique of choice to treat refractive errors. Of course, we are still in its infancy. So the hyperopic studies are going on. We ourselves have done 100 eyes in the study environment for hyperopia. Hyperopic treatment on the corneas always have limitations with whatever we have tried. And it is going to have limitations still even with a procedure like SMILE. But I think that up to 4 diopters or so, hyperopic treatments would work very well in the SMILE, as SMILE procedure. Retreatments is not a big issue today. You can do a surface ablation, or you can add femto shots around the cap by a special software which has been designed called the Circle software, which converts the cap into a flap. So you still need your excimer laser, don't throw it away, but it is used only for these very rare incidences. You can, if you are already into refractive practice, think about how many patients need hyperopic treatments, how many patients of yours need topographic link treatments, how many patients would require true wavefront guided treatments, and how many patients would need a retreatment with such high predictability as has been offered with a SMILE procedure. So you don't throw away your excimer laser. I'm not saying that at all. But if today somebody comes with a myopic refractive error up to -12 diopters, and if I have a choice, I would definitely want to opt for SMILE as compared to any other procedures that have been described so far. Thank you so much.